Hello, and welcome to On Becoming a Healer. I'm Stefan Kertes, here with my co-host, Saul Weiner. Hi, Saul.
Hey, Stefan.
Our topic today is to talk about race as a biological variable in clinical algorithms for diagnostic and clinical decision-making. Before I introduce our two thoughtful guests, Saul, I'd like you to say a bit about why this topic may be so resonant with our listeners.
Yeah, thank you, Stefan. You know, when I was preparing for this episode, I started to reflect on when I first heard the phrase, race is a social construct. I can't exactly recall, but I remember at the time just being a little bit baffled by it. I wasn't quite sure what that meant. I thought, what does that mean? Like race, he's black, she's white, it seemed black and white, literally black and white. And I was just baffled by it. And I don't remember if that was before the millennium, like that was before 2000 or after 2000. And I mention that because I think it was around that time when we started to get irrefutable evidence from the human genome that race simply just doesn't exist. It's not a biological phenomenon. We're greater than 99% the same as a species, that the differences are greater within so-called racial groups than between them. And to the extent that there are clusters, they don't even correspond to race. And when I started to learn more about the historical context, I came to appreciate that race was created for a reason. It was created to justify, at least in this country, enslaving a group of people for exploitation. And so, of course, that's not going to have a biological basis because that's not why it came into being. So more recently, I started to also hear that race, as it's been baked into our clinical algorithms, is also maybe not something that belongs there. That also initially kind of surprised me, maybe not quite as much, but I started to reflect that way back in medical school, I acquired the habit of just saying, this is a 67-year-old African-American male, or this is a 52-year-old Caucasian female. I never thought that much about why I was saying that. But then when I started to hear about these clinical algorithms over the course of my training, I was like, oh, well, that's why, right? It's because it matters. And so once I started to hear that questioned, again, it was sort of another revelation I started to try to sort out. And I was like, well, wait a minute. If it's supported by data, then it must be real. And I think what I've come to appreciate and what we're going to be talking about today is that it's easy to confuse race with racism. Race may not exist, but racism certainly does. And one of the most insightful writers who's influenced me is Ibram X. Kendi. In his opening chapter, How to Be an Anti-Racist, he actually talks about his own anti-Black racism as a Black male. And one of the things he says is we've got to get past thinking of racist ideas as a pejorative, to say, oh, that person said or did something racist, as a pejorative, because he says if we do that, then we shut up, we get frightened, we don't want to admit it. And we have to understand it's just something that's so baked into everything that we have to just recognize the harm that it causes and talk about it and expose it and deal with it. And when I heard one of our guests give grand rounds recently, this was something that she sort of alluded to. She talked about the fact that the scientists who created these clinical algorithms and put race into them weren't trying to be racist. They weren't trying to harm anybody. They actually thought they were doing the right thing. And so I think it just shows how these things worm their way into our work. And, this is actually, I believe, the fourth episode in which we've addressed the topic of how we as physicians, as healthcare professionals, often are unwittingly co-opted into systems of oppression, into structural racism. Just thinking about some of the earlier episodes, the one that was released actually in November, as you know, is titled Drug Testing at Time of Birth, How Physicians Are Co-opted into Harming Families. And then before that, we had My Patients in Shackles, Can We Take Them Off? And then before that, we had one titled Urine Drug Screening, How It Can Traumatize Patients and Undermine the Physician-Patient Relationship Without Helping Anyone. And all of these explore from different vantage points how we as healthcare professionals get sucked into these systems of harm without really meaning to. So I'm excited to explore what I think is a very important area that we haven't had an opportunity to talk about, which is the way in which this has become a part of our clinical algorithms, both at the diagnostic and treatment level, and what we can do about that. So anyway, back to you, Stefan.
Okay. Thanks all for setting us up. So our two guests, Doctors Natasha Lloyd-Nichols and Bijal Jain, are both faculty at Northwestern University Feinberg School of Medicine. Both dedicate most of their time as hospitalists and clinical educators at the Jesse Brown VA Medical Center in Chicago, where they have both been leaders in addressing health equity. Dr. Nichols co-leads the Jesse Brown for Black Lives Task Force, an interdisciplinary hospital-based health advocacy committee focused on addressing racism in healthcare that impacts veterans and staff. And Dr. Jane co-chairs the Clinical Algorithms Committee, whose mission is to dismantle race-based clinical algorithms within the VA and nationally through education and advocacy. Welcome, both of you. Can I call you Natasha and Bijal?
Yes, thank you so much for having us today.
It's a pleasure to be here.
Oh, it's great to have you. So I'm going to try to set this up or walk us into a discussion that's first going to focus on race as a correction factor that can sometimes appear in clinical calculations, often used for assessment. And then we're going to turn a little bit over to race as a factor in clinical care algorithms. So let's talk about kidney function first. We as doctors usually get a blood test that shows the level of something in the blood called creatinine. And off that creatinine, we estimate how well the kidneys filter. And there's a number. The higher, the better. This number is calculated. It's calculated by inputting certain information about the patient plus that level. And I am curious about the role of race in how we do that calculation.
Yes, absolutely. So up until recently, when we were calculating a patient's kidney function, we would use a calculator to estimate what we call eGFR. That's the estimated glomerular filtration rate. And some of the formulas that we were using that have, such as the MDRD or the CKD-EPI equation, would factor in biological determinants such as race, age, and sex. And in the case of race, what it would do is, if you were of the Black race, it would actually output a kidney function that was 21% higher for any given creatinine value. So creatinine is the endogenous factor that is often used. When we're actually using calculators that estimate kidney function, what we have to realize right from the get-go is that they're exactly that. They're estimating. They are not measuring your function. Okay, that would involve using a exogenous substance, and given the cost and the time it takes to perform such a elaborate testing, it's not really used in standard practice. So in lieu of that, what we often use is estimated calculators, and we use endogenous factors such as creatinine, which is a product of our muscle, or another factor such as cystatin. So calculators such as the MDRD and the CKD-EPI equation, they factor in creatinine. Previously, there was a long-standing falsely held belief in medicine that patients who are Black have higher muscle masses, and this results in them having higher levels of creatinine. And so what then was assumed was that Black patients with the same creatinine had a higher kidney function than white people who had the same creatinine. And what that basically suggested then was that for any given lab value, Black patients would be presumed to have a better kidney function.
I think of this value from the laboratory test, the creatinine. The higher it is, the worse. But then you look at the equation and it tells you whether to worry or not. And basically, the correction factor, the false correction factor for Black race, in a sense, it tells you, hey, don't worry. This number of 1.6, which would make me worry in most people, if you introduce that little race correction, which estimates the kidney filtering function to be higher, it says, relax, not a big deal. They're Black. That's why that number is higher. And the problem is that underneath it all, it's not clear that that's true, right? That original assumption wasn't correct in the first place. Is that a fair way of stating it?
Yes, and when you actually look at all the trials that actually led to this conclusion to be made, not only was there underrepresentation from a diverse population across the globe, the population that was selected or was studied in these trials, it was limited to populations of, say, a certain ancestry and a certain background.
To elaborate a little bit more on this topic of the harm that you're seeing with these calculators, think about it. These are the basic tests that we use to diagnose kidney disease. And so if you have a calculator in our paper, we actually pointed out this example. If you have a patient who is a Black woman or a white woman, exact same age, same weight, coming in with just a routine screening for their kidney function, the white patient, their calculation for their EGFR would come off as, in this example, we had it as 18. And this is important because there are actually hard cutoffs that we use in medicine when it comes to who gets a referral to a transplant or a nephrologist. And so, although these are estimates, we are actually using them in clinical practice as hard cutoffs. And so, I think when you see that the patient, in this case, a Black patient, their EGFR will be calculated as 21, 22, which is just 1 point above this 20 cutoff. And so this 1 point difference occurs in patients who are exactly at least the same weight, the same age, the same size. You have an output that's going to create two different lanes of care for these patients. You see the patient whose EGFR is identified as being low and concerning will be able to get the nephrologist. They're going to be able to get their follow-up appointments to see if they qualify for a kidney transplant. Whereas the other patient who's really, really close, they have to wait a few more months or years to be able to show that the disease is actually present. And only by switching out the race correction factor is what's leading to this different path for our patients. And so for the Black patients, they're not going to get offered the transplant. And so you can see that's a really big difference for care in our patients when it comes to treating kidney disease. One is offered a cure and one has to wait until their disease is evident on the lab before they're even identified as being someone who needs this treatment or this management.
And so this is really important because when you think about disparities in health outcomes when it comes to kidney disease, we know that Black patients not only have more, they bear the higher burden. So if you think about the US population, Black population represents about 12% of the US population, whereas they share up to 35% of the burden of end-stage renal disease and dialysis patients. And Black patients have faster progression of to kidney disease once they are diagnosed. And so when you think about these disparities, they really come down to calculators such as the EGFR one that result in a delay in diagnosis, a delay in implementing medications or processes that would delay progression, as well as a delay in, as Natasha said, referrals to nephrologists, nutritionists, and for transplant. All of this ultimately leading to a higher morbidity and mortality when it comes to kidney disease.
I think that's helpful. And I want to make sure I verify this, that I get a lab value and the estimates that are derived from that lab value used to include, or in some places still do, include race as something that implies better kidney function than is actually there. Has mainstream nephrology, for the most part, agreed that those estimates are actually faulty, that they were never quite right in the first place, or is that completely still disputed?
I think I can speak a little bit to this, in that when our group started to make this plan to address the use of race in EGFR calculators at Jesse Brown, we realized that, for one, it was actually pretty well established that race was causing harm, at least at the time of us taking on this project. There's numerous study highlighting that calling concern about the use of race in clinical algorithms sort of being directly contributing to exacerbating disparities. And so that information was pretty known. What was unknown, and I think what we noticed when we're talking to some of the leaders who are important when making this change, is that although they recognized the harm that was being done, there was a lot of concern about replacing the calculator with something that was more perfect. And before we could eliminate the change that we currently have, before we could remove race from the calculators, that we needed an even better calculator, that we should not make any changes until this perfect calculator existed. And so, although there was interest in making the change, there was delay in pursuing this pathway that we were proposing, which was a race neutral calculator, because of concerns that the change would lead to harm itself, actually, either harm to Black patients in particular. There was actually concern about that. Namely, by making this change, there was some question about, whether this would prevent Black patients from getting necessary medications, prevent Black patients from getting contrast studies. And so we argued, well, with the current calculator, there's this false elevation of their GFR in the first place. And so we're arguing they shouldn't be getting these meds. And currently, this is harmful. Other concerns that we did hear about would be that, we shouldn't make one change locally. We probably should think about making sure that whatever we implemented, it was uniform across the systems. And so again, the delay was, let's wait until we come up with this perfect calculator that we can roll out once, and we wouldn't have to do this like multiple changes at a time. And so, our argument for this was, well, at least for the EGFR calculator, there were programs, I believe Beth Israel Deaconess had changed to use a race neutral calculator in 2017. And so here we are in 2020, I want to say it was 2021, where we're talking about making this change in the middle of a pandemic. And so there's even less motivation to focus on these issues when, remember, we're talking about getting vaccines, et cetera. That was really the priority. And so I think those were other delays is, we don't want to be different just yet. Let's make sure we roll out, at the same time. And we really push to say, there are already discordant labs currently. You have physicians who work in multiple affiliates. They may work at the VA in one instance and then go across the street to take care of their clinic patients at one of the universities that is using a race neutral calculator. And so this is already the problem, is that we shouldn't delay a change because we're worried that labs will be different across the country. That is the case currently. And so we just, these were more of the concerns that were coming up to make sure that whenever we make a change, that we were going to make the right change and it was going to be beneficial to as many people as possible. I think that was really the core of the hedging on change.
So when there's hedging like that, it sounds like the intentions might actually be fairly good in a way. It doesn't even sound like they're disputing the scientific issue at hand. They're saying there could be a problem here, but we don't want to act yet. Is that fair to say?
That's fair to say, for sure.
And I guess that is a hard question sometimes. I've been in many, many conversations where people agree there's something wrong, but we're not sure we should fix it yet. And that's probably a larger issue that we can go to. Yeah.
Well, that was actually a really common comment was, oh, we don't know what to do, so let's not make any hasty moves until we do know for sure. But we argued that was harmful and the inaction was harmful.
Yeah.
That while we're waiting to come up with a more perfect solution, we are already seeing discrepancies in our day-to-day activities. And so similar to clinical trials where you have two arms of the study and harm is identified in one arm, you don't wait for a perfect solution to come up. You just abort the study and you say, we're not going to do that over there. This is harmful. And that's sort of what we were arguing, is that using race in itself is wrong and we shouldn't use it. That was the essence of our argument. And so part of the education in addressing these obstacles was to give the encouragement. It's like, we do know it's harmful. And so do we just keep causing harm as we go along? We argued that was more harmful to our patients, knowing that we're sitting on this
and I think a key point that you also, I just want to highlight is it's not just that it's sort of wrong in some sort of philosophical, ethical sense. It's that at a practical level, these false measures seem to tip the balance in almost all cases in ways that cause delays in needed care or not even getting a correct medication. So if you're saying somebody is less sick or less needy of services than they really are, and you're not referring them, whether it's to a specialist or to a transplant surgeon, or in the case, as I recall from Bijal's grand rounds, to ACE inhibitors when they need them. In all cases, it actually leads to substandard care. And I think that's what bears mentioning here, in addition to just the fact that it's at some level just fundamentally wrong. It's that it's actually causing a harm. And I think your point was that if this were a clinical trial, right, we would, as you said, stop the study, and change our plan. And that's what your concern was that was getting delayed. Is that a good summary?
That's a great summary. And, I think another clear example of this that is different than the lab, because I think that can get a little bit tricky for those of us as we're trying to understand that. But I think an even clear example would be with the use of the calculators that we use for determining who gets a vaginal delivery or C-section for their second child. I think this calculator, the harm of using only the race Black, white, and the ethnicity Hispanic being the one that would give you points that will say you shouldn't offer this woman a vaginal delivery. Instead, they should get a C-section. So when you look at the studies that were used for this calculator, it wasn't just race or ethnicity that led to these poor outcomes. It was whether they had insurance or not, whether they were married or not, all of those other factors, but those factors were not included in the calculator. Only race was left.
So that's so interesting and important. I just want to kind of say it back so nobody misses this, which is that insurance status, marital, all of those things were actually predictive of whether somebody was more likely to have a complication of an attempted vaginal delivery after C-section. But nobody thought of putting those into the formula. The only one they thought of putting in was, oh, they're Black. So first of all, that's odd, right? And secondly, what it led to was that if you're Black, you're more likely not to have a vaginal birth after C-section, which of course sets you up for a higher rate of complications. And you're already a population that has higher maternal mortality. And so it's just yet another example of the harms that come out of these embedded racial markers that are used in the calculations.
Yeah, many of the consequences or the unintended consequences of these algorithms is that they do end up reinforcing the structures that led to these disparities in the first place. And so when you are ascribing observed differences in health outcomes to being related to race, you're basically turning a blind eye to some of the root factors, the factors that are rooted in systemic or structural racism that actually do lead to these differences. And, some of these are modifiable, but the first step to actually making a difference is to acknowledge that it is the impact of racism that has led to these health outcomes and these health outcomes that do fall along racial lines. And so one of the things that I've learned through my research over here is that perceived discrimination, skin color, stress, all of these have a significant negative impact on your biology. It has an impact on your stress response. It has impact on your inflammation, immunomodulation. And it is this as a totality, which we call the allostatic load, that actually leads to some of these complex phenotypes that we end up seeing. And so to ignore that aspect of it and just think about race as a monolithic category that has inherent biological differences, it really does prescribe to this notion of biological determinism and scientific racism, where there's systems and policies in place that perpetuate the hierarchical system that kind of give birth to these systems and practices to begin with.
One of the examples that I came across while looking at some of the reading that you guys have mentioned and then you've talked about in your grand rounds is that the original calculations were being done of lung function, and it was determined that people who are Black have, say, quote, worse lung function, but don't worry about it because it just means that, it's a biological marker. That was the false notion. It actually turned out that when those measurements were originally taken, they were done with a population of people who are Black and were actually living in an environment where they were exposed to a high level of air toxins that were well known to cause lung damage. And so that got baked into the data. And then all of a sudden, years later, we're saying, oh, don't worry about this person's lung function. It's fine. They're just Black. And I think that, to me, that really stood out as an example of how these things can just get baked in historically, and then everybody forgets about it, and then all of a sudden we're using it for years. Am I describing that accurately?
I'd say quite accurately. That was part of what we found when we were in the research phase of our projects. We were noticing when reaching out to other programs who had already made strides in these areas, we were sort of learning from them that they were surprised to learn as well that this was the case for their equipment. We would reach out to various departments, the leads of their pulmonary function labs, and they would say, oh, no, we're not using race in our, there's no race in this. And so we had to go through explaining how the computer is already, it's already embedded in the computer, and the printout that you get, this is already done. So I think that was really shocking to a lot of the physicians who are leading these pulmonary function labs, because they felt like they weren't part of that process and that their lab was different. But realizing that, like you said, that it become embedded into the equipment, it's in the calculator, the report just punches out a printout. And even more concerning is that oftentimes when we were trying to inquire about how is race determined for these patients, and oftentimes it's based, like Dr. Bijal Jain had mentioned, that it's based on the technicians visualizing physical appearance of a patient and stating then what their race is, with the options being black, white, or other. Again, when we're talking about being valid, when we're talking about using accurate measures, it doesn't seem to be very accurate if we're then using a guesstimate of what someone's background is.
I was just going to speak a little bit more to what Saul was mentioning, that the studies that were done to sort of make some of these conclusions and justify the use of race in the pulmonary function test interpretation, they were really done in a limited population, not only with these marginalized communities that not only face certain environmental exposures and pollution levels, but if you think about early life nutrition, if you think about the physical activity levels, if you think about respiratory infections, all of these set them up to having likely poor lung function overall. And then you use these and you normalize them. You normalized lung function, like basically call it race norming. And it really speaks to the fact that not taking into consideration all of the external factors that impact our health. And if you even think about pulmonary function testing, and in 2012, around that time, there was this big celebration of this introduction of this new way of interpreting pulmonary function tests using GLI reference points, so Global Lung Initiative. And they really prided themselves on gathering data from populations across the globe. And so they divided the populations into white, black. In fact, they, as far as Asians are concerned, they had Northeast Asians and Southeast Asians because, I don't know, somehow a geographical boundary like separated people. I have no idea, but they were really proud of the fact that they're like, okay, now we have these very personalized race-based ways of interpreting. And if you look at the Black population that they used, they were all Black Americans. They did not, there was no representation from African Americans, from Africa, South America, from all over the globe. And so this idea of like race norming is twofold. One, unless you are literally getting populations from across the globe, you cannot make these kinds of generalizations. And second, you are very much ignoring the influences that the environment and other, social determinants of health play on your lung health from infancy to adulthood.
Just as a point of contrast, physicians look at a lung function result and it's always compared to a norm. And we sort of agree that a very small person would be able to move less air than a very large person. Like that's a very plainly obvious differentiator. We don't expect the same amount of air to be blown out by a person who's 4'9" in 1 second compared to a person who's 6'5". Mm-hmm. But race norming doesn't really make much sense in that context. There's not really a reason why two people of the same size and weight would generally blow out different amounts of air in 1 second simply because of the pigmentation of their skin. But in fact, as you point out, there is this history really dating back to the 19th century, which said, hey, where we're looking at African Americans, it's just normal to have 18 to 20% less air blown out during 1 second, which obviously in retrospect seems kind of bizarre. Mm-hmm. And it's only this year, 2023, that the American Thoracic Society determined that actually doesn't make much sense, which gives you a sense of the strength of the hold of these ideas on how we consider care. I do want to give you an opportunity, particularly Bijal, in your grand rounds, you spoke about this. I think most people can sense that there are sometimes biological correlates of ancestry. And sometimes ancestry is related to the amount of pigment in your skin. So I guess sickle cell anemia is more common in people who seem to have more pigment and have families that originate in West Africa. Saul and I talked a lot about this last night. Ashkenazi Jews, where there's a ton of essentially tendency to mate among people who are already close to you, which is really specific to that background. There's certain disorders that can emerge in that context. Do you want to help us distinguish a little bit between race versus ancestry?
Yes, absolutely. I think it's also important to distinguish skin color from ancestry to begin with. The story behind the skin color is actually a really interesting story. Skin color is really powerful. It is what we use 99% of the time to describe racial groups. But when you think about skin color and you think about the fact that all human beings originated from Africa, and Africa is located central in terms of the equator, so it's located in an area of high sun exposure. What we have learned now through the Human Genome Project and through studying ancestral roots and genetics and whatnot, like how genetic variation comes about, what we've learned is that back many, many hundreds of thousands of years ago, with the high levels of sun exposure, there was a problem in folic acid. So sun exposure breaks down folic acid, and that would lead to birth defects. And so that was not sustainable. And so actually there were mutations that arose that led to higher pigmentation in the skin. And this is not led by just one gene. It's actually multiple genes that play a role. But the phenotype that resulted was a higher pigmentation. Melanin is like the grouping of all the different skin pigments that lead to a darker skin. And that actually conferred a survival benefit. And so the population in Africa at that time, and this is really the Central Africa that's located near the equator, those who had darker skins survived. As humans started migrating out of Africa, they started moving away from the equator. The problem then became vitamin D absorption. And so then there were survival consequences related to decreased vitamin D levels. The problem was not with folic acid because the sun exposure wasn't there to break down folic acid. However, the problem became vitamin D. Then arose independently in different areas of the world where there were low sun exposure, mutations that led to lighter skin tones. And that conferred a survival benefit. So really, at the end of the day, skin color is really a manifestation of the amount of sun exposure you have and the battle between vitamin D and folic acid and survival.
And, just building a little bit on that when it comes to sickle cell, because I think that's often the question that we have as physicians of like, how do you reconcile sickle cell then? Especially since a large percentage of Black patients in America, that sort of is a subset of individuals that we have come across as physicians. But when you look across the globe, you will see that this is actually a geographic problem, which is impacting not just individuals who are of African descent, but also who are of Middle Eastern descent as well. And so certainly we are just getting it's sort of a population that we have seen here. And it's not that Black people inherently have sickle cell. The question is, why is it that so many Black people have sickle cell in America? And it's really just more the migration that came afterwards. And that group of population is concentrated as a result. But it does impact individuals of Middle Eastern descent and others as well.
Sickle cell trait was a random mutation that arose that conferred a survival advantages in areas where malaria was endemic. Okay. And so in these areas, just having one allele, just having the sickle cell trait allowed you to survive through epidemics related to malaria. Okay, so now we look at sickle cell disease where there's two alleles. We look at that and we say, okay, you only see it in African populations, but that is, as Natasha said, that is absolutely not true. The trait is there in any country that is endemic to malaria. And a similar thing arises when we think about kidney disease. There's now a increasing recognition of this allele called ApoL1. I don't know if you guys are familiar with it, ApoL1.
No.
So ApoL1 is a genetic variation that arose initially in West Africa. And it actually was a random mutation that occurred as a result of African sleeping sickness, which was deadly. And so it conferred a survival advantage. So having one allele conferred a survival advantage. Having two alleles actually increased the risk of early kidney disease and end-stage renal disease. And what we now know is that people who have any kind of African ancestry related to West Africa, they might carry this allele. If they have one allele, it's not too bad. But if they have two, that they are at about 15% higher risk of having adverse kidney outcomes. Even in those patients, though, it is not just because you have it, that's what it is. So sickle cell trait is more of a causative mutation. If you think about APOL1, it's more of a predisposition. So it's having the two alleles and then being subject to certain environmental influences, such as certain viral illnesses. In the case of APOL1, if you have HIV and you have APOL1, both high-risk alleles, then you have like up to 200 times greater risk of earlier kidney disease and end-stage renal disease. And so it's a very complex thing. And one thing we've actually now learned and accept is that almost every disease that you can think about, almost every modern disease that you think about, going from cardiovascular disease, hypertension, coronary disease, strokes, they are very complex. It goes far beyond your genes. The environment plays a very dominant role. Okay. And the Human Genome Project has taught us that, as Sahil had mentioned earlier, that human beings are 99.6% the same. Okay. And you had asked earlier for to sort of make that distinction between what are we talking about when we talk about ancestry and certain genes that do kind of pool. I think it's important to just take a little bit of a lesson in genomics to really be able to grasp some of these key concepts. Okay. So we were all in Africa. There was migration within Africa. And that migration over hundreds and thousands of years created distinct genetic groups. Okay. So when you look within Africa, there are distinct genetic ancestries related to West Africa, Central, South, etc. When people started migrating out of Africa, they migrated to Europe, primarily from Western Africa. So if you actually were to look at the genetic makeup between West Africans and South Africans versus West Africans and Europeans, what you'll come to see is that there's more genetic similarity between West Africans and Europeans. Okay. There's more differences between what we now racially call Black persons in Africa who come from West Africa versus South Africa. Now, fast forward thousands of years to our present day, what we kind of call the melting pot, right? We have had generations of interbreeding, mixing. Our ancestries are all mixed. They're all mixed. Okay. And over time, mixing between populations has led to what we see now as a mosaic of ancestries, okay? And it cannot be decoded by skin color. So if you look at any one of us and we decode our ancestry, we'll come to realize that all of us share a certain amount of what they call European, Asian, African ancestry. And when you dive even deeper into what is African ancestry, there's a big difference between West Africa, South Africa, etc. So certainly there are diseases that do arise from people who share a large amount of West African ancestry, like the APOL1. Okay, so people from West African ancestry might have a higher chance of having this genetic variation. But can we say that all people who identify as Black have the same risk? We cannot say that, because then we know that ancestry is very different from your skin color, and your skin color is what is used to assign race.
I had written to a physician who also was a mathematician about this issue, and she focused on the idea that ancestry could be quantified genetically, but that there's no clear correspondence between the continuous variable of genetics and the categorical that people may adopt, that is, quote, race. And so she just doesn't see much use for it.
I absolutely agree with that. When you think about race itself as a social construct, I think that is an abstract idea. And I know when I first heard it, I didn't really understand what it meant when people were saying race is a social construct, and really made me go back into the history of how race even found its way into our life and society. And as we know, race was a manufactured category that was born at times of enslavement. And it really was a human hierarchical grouping system. And when we think about race and what it really is right now in America, it has evolved. It's evolved according to what the current day social political like kind of atmosphere has been. And so currently we identify 5 race/ethnicities in our US Census data. But if you go back like many decades ago, we only had 3. And there's some countries that identify 20 races. So race is a very fluid, dynamic kind of a social idea that depends on where you were born, when you were born, where you traveled to. All I can say is it's manufactured.
Would you be able to move us a little bit into the domain of clinical algorithms and decisions? Particularly, I'm curious about race as a factor that's in the guidelines for blood pressure treatment. I was trained in an era, maybe late 1990s, very early 2000s, where they did talk about, hey, if your patient is African American, your first therapy choice for high blood pressure might better be a diuretic like hydrochlorothiazide or maybe a calcium channel blocker, but maybe might less well be one of the drugs we call ACE inhibitors. For the non-medical folks, those end in pril if you have one of those. And gradually that kind of fell by the wayside in my practice and in the organizations I work in. But then I took a look at the guideline from the American Heart Association, and they kind of landed on that again. And I wound up wondering, are we securely anchored in this argument that if somebody has the race of African American, which is kind of not a race, but a nation where someone, it's kind of weird. We just talked about how complicated this is. Are we securely anchored in science when we say somebody with the, quote, race category of African Americans' first blood pressure medicine would be better one thing than another?
I think hypertension is just, once again, another example where they used observations from these trials, and they basically explained away these observations using non-scientific justifications that, okay, these observations that fall along racial lines are due to some inherent or innate biological differences between races, which is, absolutely not true. And, I could talk about this for a long time because when you actually take a deeper dive, there's a lot to be said about these studies that were supposedly scientifically rigorous, but there was a lot of limitations that affected the outcomes that we're seeing. But when you just take a step back and you're saying, hey, Black patients respond differently to certain medications such as ACE inhibitors. And the justification used to kind of explain that was this concept of Black patients as a whole group, as a whole population, have low renin, and that's why they don't respond to ACE inhibitors. We just spoke about how it is just absolutely not possible, right? Like, it's not possible. Hypertension is a very complex disease. Each and every one of us has different drivers to our blood pressure. And there are multiple physiological systems that come into play, multiple neurohormonal systems that come to play. And to think that there's only one, to even think that hypertension itself is just a singular pathway is wrong. And then to think that all patients of one race have only one biological way that they would respond to treatment is also wrong. The whole idea of it doesn't make sense. And it's important to kind of acknowledge that, because just like in the case of eGFR and pulmonary function testing, what this is resulting in is inequitable access to a very important treatment. Studies after studies have shown that ACE inhibitors and, say, ARBs and agents that combat the renin-angiotensin system play a very significant role in delaying kidney disease and in improving cardiovascular outcomes. And when we're basically saying Black patients should not receive ACE inhibitors as first-line treatments, we're delaying the initiation of medications for patients who are already at high risk. And just like kidney disease in hypertension, Black population, Black patients have earlier onset of hypertension. They have faster progression of hypertension. They have higher morbidity and mortality related to hypertension. So now you're taking a medication that has proven benefits for all of these outcomes, and you're delaying initiation because you're saying that they don't respond to those medications. And not to get too into the weeds of ACE inhibitors, but it also sort of ignores the fact that there is circulating renin-angiotensin levels, and then there's tissue level. And we know now that tissue level, renin, angiotensin, aldosterone, all those factors actually play a bigger role in leading to some of those end organ damage and outcomes that we fear. And patients who have high levels of tissue may have low levels of circulating. Patients who have high levels of circulating may have low levels of tissue, renin, angiotensin. There's no correlation. And so there's multiple levels where this idea that Black patients don't respond to ACE inhibitors, it just breaks down and doesn't make any sense.
I do think all of this still gets back to the idea that we wanted to impose and structure our understanding of information from American trials primarily based on a category that people who might deem themselves or who we deem African American by virtue of pigment are a relatively homogeneous group, which best we can tell the opposite would be the case, that there may be more homogeneous genetic groups. For instance, my own group, Ashkenazi Jews in Eastern Europe before they moved to America, or maybe the Amish if they stay in the Amish community. But actually, for good reasons, but also tragic ones, African Americans are actually one of the most heterogeneous genetic groups. So to hold fast to that grouping is at odds with what we know about genetics. I want to turn to how we change the healthcare systems that we work in, particularly when they have policies in place, such as an algorithm to calculate kidney function or an algorithm to calculate the likelihood of needing a cesarean section. And it seemed to me, Natasha, you've done some work on this in your own hospital and nationally, and I was hoping you could give us an example of where you've begun to approach trying to change a system and what it required.
Well, this question is really related to the group Jesse Brown for Black Lives Task Force. Our committee was founded on the principle of addressing racism in healthcare within the Jesse Brown Hospital. This started actually because one of the employees, someone who was in a supervisor type role, had made a comment that there was no racism at Jesse Brown.
Great.
And so
good to know.
The staff who were in this conversation were sort of like, hey, I disagree. And so that sort of was where we felt, this founding member felt like we really did need to make not just a short-term response to the George Floyd murder, but also something longer term where we could address the education deficits that were surrounding racism, the presence of racism in general. We were sort of starting there. But the key to our success as a group has been, the number one factor has been having supportive leadership and recognizing that although a lot of the efforts that we have been bottom up, that the most effective, you're going to have the most influence if you can actually start top down. And so when it comes to making changes at your local hospital, that's been part of our success, was having leaders who valued this change, recognizing the harm that has been done for so many years, and feeling as if our hospital as a general, this was going to be a priority for us to show that in order to provide excellent, exceptional care to all veterans, you do have to address the disparities that are impacting subgroups that we've been talking about today. And so key is getting buy-in from leaders who are able to make the change. And the second part has been the foundation of our ability to make changes with the key stakeholders has been education. There's been so many times where we're choosing our project, we're doing the research, we're reaching out to others who have done this work, where we find that even the people that are responsible for making the change may not be aware of the history that we're talking about. The key to our success is making sure everybody's on the same page with where we are with the issue before we would even introduce an intervention. And so a lot of that comes through grand rounds presentations. Dr. Jane had presented in Madison, sort of raising the awareness of this topic. But we've been doing this for 3 years now, but there are many instances where we meet other hospitals who are still using the EGFR calculator or who are still using race in their PFT testing. And so by sharing the education component, they are able to also share that with their groups to make these changes in their facility. So that's been the key, the education of getting on the same track with the literature, making sure we are able to identify what the current barriers are so we can teach the differences, and then we're on the same page at that point.
I was going to say, I think our experience has been that in the beginning of our advocacy work, the conversations we would have often placed us in a position where we bore the burden of proving. So we'd have to prove that there were inequities. We'd have to prove that there was harm done. And then we had to prove that there wouldn't be harm done by stopping the misuse of race. Because we've been using education as a tool to get some of this buy-in, because we've been sort of equipping people to be able to criticize and interrogate some of these practices by informing them and educating them not only of the history of racism in medicine, but just the scientific basis of it, the Human Genome Project. Now our conversations can move beyond focusing on having to prove something, and they can actually focus more on what do we do at a systems level to build equity.
Just sort of building on that, just a little view into some of the process we had when we were trying to make the change with the EGFR at Jesse Brown. Before we initially presented our plan of leadership, it was received very widely, sort of very high support from our leaders. And part of the process with making change is you have to get the Midwest leaders to also agree with the changes that you're making. You can't just make one change at one VA. You really do have to get the leaders who are over the Midwest network to agree to this change. We presented our proposal to them. They were excited as well. But then we received pause on our project from the national leaders who said, hey, we don't want you all to come out with any changes at the local level because, hey, the guidelines aren't out yet. We don't want to make a change here, and then in a couple months, the national guidelines will be coming out, and then we'll have to switch again. And so we felt that this delay, which was at this point, it was becoming months of delay of emails and trying to, essentially we're told, why don't you do a pilot project instead? Let's not change the race, let's not change the whole thing everywhere. Why don't you do a little pilot project within your institution, show that this is actually not going to increase the consults to nephrology, not going to cost that much more in resources before we think about rolling it out into the whole VA. Are we going to be able to handle the demand? Was really a concern that we were going to show a change that would reveal the true nature of the disease of these patients, and how would that flood the system. There was pushback to say, hey, before we roll that out, we want to make sure we're not going to flood our consultants here. And so a meeting that we had with the national leaders, we were supposed to talk about our pilot proposal and what we were going to do, but instead we said, let's bring the whole committee with us. And instead of talking about this pilot, let's actually go back to where we were, which is race should not be included here. And we really want to hear from you all. What is the delay? What is the hesitation to make it? Because they've already identified it as a problem. And so through this conversation, it really was evident that the hedging was coming from the little guys, the hospitalists, this little program telling our top leaders what they should be doing. That's not traditionally how things are done. Traditionally, there are large expert guiding bodies that tell us as a medical community what we should be doing. And so getting instructions from a committee like ourselves, that was, do they really know what they're talking about here? They're not usually the group that's making these recommendations. And so from the time we started the project to the time we were able to implement a race neutral EGFR, it was really quickly after the NKF ASN guidelines came out, which was I believe it was in September of 2021. And traditionally, we were credited for helping, our advocacy was help with crediting, getting the VA, especially Jesse Brown, to implement in a quick fashion, because in November of that same year is when we implemented at our local institution, followed by rollout in January for the whole VA. But prior years, with the introduction of the MDRD calculator, it took 8 years from the publishing of the guidelines to when they are actually implemented. And so we felt that obviously it's an unacceptable pace, to wait for change. And so we were really pushing to change quickly, even after the guidelines came out.
I want to ask one last question, then turn it back to Saul for a moment, which is whenever you reference to your coworkers or to your leaders, we've been relying on a category for race that is not biological, and we have been making decisions that are often disadvantageous to people who are Black in the United States context. We need a change. I can imagine many people saying, are you saying I'm racist? And not in the Ibrahim X. Kendi version that Saul's laid out at the very beginning, but more like, are you saying I'm racist in the common way that people use this word, which applies animus toward other people? Or they wouldn't necessarily say that. They might just say, I definitely am not racist. I just want you to know that. And I wondered if you encountered that kind of conversation, or was it generally not even on the table?
You get it in a different way. So we'd send our evidence and we get evidence back that fit the other narrative as to why we needed to slow down. And so it was less about being called out on the practices that we were responsible as like current system. There was a lot of concern about what the harm would be to the patients in revealing this information, the harm of letting patients know that we've been using these calculators for so long. How are we going to deal with that consequences of patients calling and making their voice of concern saying that, we were doing this? A lot of patients still didn't know. And so there was a lot of concern about, making sure that when we roll this out, that we had our messaging was going to be appropriate for patients and providers, because certainly we weren't the ones who made these calculators, but we were trying to explain what had been done and how we're undoing it. And a lot of that language was saying that data at the time was limited. It was less data. We know more now. The truth is this. And so we are trying to uncover the truth. And that's sort of the remedy. The truth would be part of the healing for patients, knowing that I've identified harm, we're no longer doing that. And that even with the patients that we see on a day-to-day basis, they are directly impacted by hearing this, that hearing that we no longer do this in our hospital. I do believe that it does deepen the trust that the patients have for the providers who are working for these projects.
Yeah, a lot of the resistance that we faced initially was common across I think across the nation, and speaks to like the history of medicine and the injustices that have been committed, and just sort of really that initial state of acknowledgement. That's a very difficult pill to swallow for many who have devoted their life to supporting some of these, like, their life's work of these algorithms and guidelines and whatnot. And so if you look at all the publications over the last decade versus prior to that, there's been a lot of censorship. People have not been able to share their stories. Marginalized communities have not been able to share their stories of these injustices. And even in early, like when it was EGFR, a lot of the times when we would come forward and say, hey, but this is wrong, it was considered inflammatory, and like you couldn't have the conversation. And so, I mean, fortunately, I think the national discourse has like shifted away from that, where people have moved beyond the acknowledgement state and now are more in the action stage of things. But really, that was the reality when all this first began.
One other comment on that is the struggle is trying to figure out what to do with race. Should we get rid of it altogether? Which is what we were advocating for these calculators. But then the other flip side was these decision trees that you were mentioning about hypertension and certain drug medications for heart failure being more useful for certain like Black patients. And so there's this community that recognizes that there is still utility in identifying race, because there are real consequences that are associated with these social constructs. However, there is a caveat there that when you're using race, it should be with this asterisk that says you're capturing racism, you're capturing social, economic factors. And so that has been part of the conversation of making sure that we still identify groups of people who need resources, but not attributing the differences that we see to race.
Yeah, I think of that as like, when you're thinking about how do we responsibly use race in biomedical like research, right? How do we use it in a way that's actually going to build equity or advance equity. I think of race as a risk marker and not a risk factor necessarily. So being aware not to be using race as a biological variable to create differences in treatment guidelines or in making diagnostic decisions, but definitely using race as a risk marker to follow, to see whether the actions or the policies that you are putting in place are actually making a step towards mitigating these disparities and actually building health equity. And so I think if we were to think about how race falls into the future of medicine, I don't think we can get rid of it entirely because we still have work to do to undo some of the inequities and harms that have been created.
One of the things that I love about this story is that it's a example of activism that matters. After George Floyd's death, organizations created these DEI committees everywhere. And people kind of got cynical about them because a lot of time it was just like, okay, everybody has implicit bias training. And that was all that happened. There were a lot of conversations. But what you guys are doing is something very specific and tangible. You're saying, we're going to worry about getting the PFT calculator changed, and we're going to get the EGFR calculator changed, like very concrete things. And it has real effects. Like all of a sudden, patients now get to see consultants, and patients get put on medications that they should have been on a long time ago, and their blood pressure is finally under control. So this is a story of activism that is practical and that makes a difference. And so I just wanted to thank you both for being, and I know you're not the only people in the country doing this, but you're doing it at one place in a persistent way, and you're making a difference, and you're bringing about change, both through your expert knowledge and also for your ability to just be persistent and push and strategic. And so I'm so glad we've gotten to share, your story with our listeners. So thank you for that.
Thank you so much for having us. I do want to give credit to the engine behind this group, the physicians, the social workers, the nurses, our pharmacists. There is a collective of health professionals working together, our trainees, to move the needle. And so although myself and Bijal are here, we are representing, there's probably 100 of us or so in the committee right now. And the group is fiery. And when we get one door that closes, the group is coming up with an idea on how to keep going. So I do want to give credit to the group, the fire behind all of the power, because as you can imagine, the work that we're doing, it's been embedded in our healthcare system for all of what we've known, how we've been trained. And so it's been helpful to have a group that's very energetic and ready to take on these topics. They're not easy to take on. And in doing so, we're showing our trainees this matters. This is something that you can do, and this is something that has real impact on patients. And so it's been great to share that with you all. Thank you.
That's awesome. Thank you.
Thank you both, Bijal and Natasha, for coming on the podcast and for allowing us to illuminate something that can get lost in rhetoric sometimes, but is incredibly practical and bears on people's lives. Thank you again.
Thank you both.
We hope you've enjoyed this latest episode of On Becoming a Healer. If you have and you haven't already subscribed, please consider doing so now. Also, please rate us on the Apple Podcast app, as it will help others find us. And if you have a few moments, leave a review. In addition, if you'd like to make a comment about this episode, we'd love to hear from you. There are a couple ways to do that. If you're using the Apple Podcast app, then just open the episode website link and enter your comment there. Or you can directly go to the website contextualizingcare.org, select the podcast tab, and then scroll down and click on the episode. There you'll find the same comment box. Finally, you can always reach us at onbecomingahealer@gmail.com.